Good afternoon. Guess what time it is, folks? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast and 3 in the West. And there is one place that you need to be, and that is right here. It's Fertility with Fink and Friends. I am Fink. You are friends, and it is great to be with you as we are every Tuesday afternoon at this time. Live from Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility, Colorado. We've got some other locations around the country. We've got Syracuse, Buffalo, and Albany. We've got Sarasota. We've got some monitoring centers in places like Atlanta and Norfolk. And everywhere you turn, we're cropping up someplace else. Dr. Kiltz has a mindset to get us all grown across this great nation of ours. How's everybody doing this evening? And I hope that your week has thus far been great and that your weekend was tremendous. Our thoughts are going out to our friends on the down on the Gulf Coast who are facing down another hurricane. Just kind of gets to be a way of life, doesn't it? I spent the last 20 plus years in South Florida. And I tell you what, being in Colorado now, it is very, very strange to not even have to pay attention to what's going on in the tropics. So thoughts going out to all those who are facing down a storm tonight. Let's see who is here with us tonight. Hello, a special hello to Angelina Foxy, the world's greatest cardiovascular nurse practitioner in Minnesota. Let's see. It looks like Heavenly Joy. Jasmine is here. Hey, Nikki Jones. We haven't seen you around for a while. Hi to Sharmila. Nice to see you again. Angela says, love the glasses. Thank you very much. Apparently, and you're not going to believe it, but I swear it's the truth. I didn't realize that, yes, I match. Okay. Yeah. Okay. Go ahead. And yeah, I know. Brandis pointed that out to me today to make sure that I felt really ridiculous and self-conscious. So thank you as always, Brandis, who also has joined there, our wonderful nurse practitioner here at CNY Colorado. Hey to Shelby, Heavenly Joy. Good to see you. Equestrian. Haven't seen you in the last couple of weeks. Let's see, the Bama Gal, who is the one and only Mama of Fink, along with the Dada of Fink in, speaking of the Gulf Coast, down in Mobile, Alabama. Thank you for being here this Tuesday afternoon. I appreciate that. Over on CNY's Instagram, Rosa, you were number one here. I think this is your second week in a row for being the first person logging in on the Instagram side. Thanks for being here. Hey to Christina, Bryn, Saffron Magic, Tamita, Faith Houston, Erica, Macro Mama, Bronco. Yeah, Faith says Broncos glasses. That was the other thing. When I got the glasses, I did not realize they are the Denver Broncos colors. I am not wearing the shirt because of the combination because of Denver Broncos, nor am I wearing the glasses. But hey, you know what? If you like the Broncos, I'm here for you, baby. Journey to Baby W. Nice to see you. Looks like Ahmad is here. Hello to you, Keiichi, Educated Minds LLC. Irina Shina is here. Sarah, here is Bryn, Marielle, and Maria. And over here on the Facebook and LinkedIn side, we've got Tracy and Marcia. Dr. Andrea is here, Janie Lynn, and looks like Marcia and Michelle. Good to see everybody here. Let's see if we can dive into some questions and try to get some things done here tonight. Equestrian asks, best suppression for positive receptiva test. Does suppression treat BCL6 regardless of whether it's endometriosis or another cause? I had a clear HSG and a pelvic MRI last November. So the BCL6 marker is considered as an inflammatory marker, and it is considered to be a marker for endometriosis. So if BCL6 is positive, we know that 60 days of suppressive medication with Orilissa or Lupron or Myfembree is sufficient to turn off the switch on that BCL6 And that is a very important thing when it comes time for embryo transfer. And why is that? Because if you're expressing that BCL6 marker, it means that your odds of being able to implant an embryo dramatically go down. The numbers that we use for that, 65% is the expected pregnancy rate with a euploid or a tested normal embryo. If you're positive for BCL6, then that number goes down to really less than really about 10%. So it's pretty significant, the difference that that makes. So if you've got BCL6, you definitely want to test for it. Now, here's a question people often have. Should I test for BCL6 should I do the Receptiva test before I ever even do an embryo transfer? And that's a difficult question. It's a question for which there is not a very good evidence-based answer. We always like to fall back on the evidence. What do the studies show us? Since, I can tell you what I think, but what I think may be completely wrong, right? So it'd be nice to know if there were studies. Well, here's what we do know. We know that in the earlier days of IVF and fertility treatment, and you may have heard me say this before, you couldn't before you even met the doctor, your laparoscopy would already be scheduled, your diagnostic laparoscopy. They would do a laparoscopic surgery on really everyone going into the process, looking to see if they had endometriosis. Laparoscopy is a surgery where you go in through the belly button, take a look around, you make some little micro punches about, maybe about 5 millimeters in size, the size of my pinky nail here, and can put some instruments in and treat things on the inside. It is certainly a preferable way to have surgery compared to the older way, which was, where everything you had to, have a big incision and be opened up. But what we learned from that was that a lot of people were getting laparoscopies who really didn't need them. And a laparoscopy, it's still considered it's an outpatient surgery, but it's still a surgery. I mean, it's general anesthesia. It's you're putting sharp implements into the belly. There's a lot of important things on the inside, bowel and bladder and blood vessels and nerves and things that you don't want to injure with sharp implements. And so my feeling is that if you don't need surgery, then don't get surgery. But in the olden days, everybody would get a laparoscopy. And what we learned from that is that it just wasn't necessary. Now, I do not recommend laparoscopy unless you have a pain syndrome, unless there's reason to believe that you may have endometriosis, because we can diagnose that non-invasively now and can also treat it. So why have surgery if you don't need it? But so if the prospect was doing a laparoscopy on everybody to find the people who had endometriosis. And we found that that is not a cost-effective solution. It doesn't make sense. You have to treat more people, or you have to rather have surgery on more people than it's worth in order to find the endometriosis in that small group, or in that group that has endometriosis. And it's not really a small group. A lot of people do have it. The same holds true for, is it worthwhile to do the test, the Receptiva test, on folks before they have had a reason for you to go looking for it? Well, some people feel like, well, I want to do it because why do I want to waste an embryo? Why do I want to have a transfer if there's a possibility that something is going to be standing in the way to keep it from working? And I completely understand that. But the Receptiva test was originally indicated, and when you look at their website, it's receptivadx.com, you will find that it talks about, it's a test for people who have had implantation failure. You keep doing transfers and they're not working, or you keep doing something to get pregnant, you're not getting pregnant. Maybe endometriosis is the reason why. Well, so should you preemptively do the test? I understand the feeling that, that feels like the right choice for me, but it does become an individual choice for you. Do you want to do a Receptiva test before you do an embryo transfer? I think it's a reasonable thing to do until such a time as someone tells us that it's not. Now, unfortunately, the Receptiva test, it's only run by one company, and it's $690 for the test itself. That's still a lot cheaper probably than what it would have cost you to have a laparoscopy. But it also has to be done during a specific time during the cycle, 7 to 10 days after your ovulation. So something to think about, and hopefully that gives you some food for thought. Let's see here. Here is a question. It's kind of a little more specific. Oh, look at there, Siciliana Melissa. We haven't seen you around for a while, and almost 18 weeks thanks to a transfer with Brandis. Gosh, we love to hear that, Melissa. That is awesome. Thank you so much for sharing there. A patient had a hysteroscopy at the time of her egg retrieval yesterday, and we found polyps. And so let's just talk about that. Once a year, we want your uterine cavity to be evaluated. It can be evaluated by a saline sonogram, or it can be evaluated by hysteroscopy. Hysteroscopy is a camera that goes inside and takes a look around inside the uterine cavity. If there's nothing there, that hysteroscopy takes all of, under a minute. But polyps are finger-like growths of fleshy tissue that live inside the uterine cavity. And when they are there, they take up valuable real estate that your embryo might otherwise wish to use for implanting. So you can have other things inside the uterus as well. You can have scar tissue. You can have bands of muscle. You can have balls of muscle, which are fibroids. You can have uterine septums, which is like a divider that goes down the middle. So there are different mechanical things that can cause problems with implantation. That's the reason that we do want to evaluate the cavity before that highly sought after embryo gets placed inside. Polyps in most cases are benign growths. They are literally like a patch of weeds. They're like a skin tag or a mole that you grow. Think about your yard. Most of your yard is pretty well, when you go mow the grass, it's pretty nice and even. And, you look at it as that grass grows, it grows pretty evenly, except for, that little patch by the mailbox. And we all know why that happens. Those are weeds, and they grow because they get peed on by the neighborhood dogs. Well, that patch of weeds is an extra growth of something that's green. So it kind of looks like the rest of the grass, but it's not really the grass itself. That's what a polyp is. A polyp is a fleshy growth. And the way I think of it is like this. The uterus, think about a little sort of city block and with a bunch of little houses. I don't know that there are houses on city blocks anymore, but think about a bunch of little houses, and each little house has a TV antenna on top. And that TV antenna is receiving the signal from the TV, and that's how the people inside the house watch the TV. Well, what happens if on top of one of those houses, instead of one TV antenna, there's 40 TV antennas? First of all, it's an eyesore, right? The neighbors don't like it, but it receives way too much signal, and it may blow out the electricity. It may blow out the TV and all the electronics that you've got in the house there. That's kind of what's happening in the uterine lining. Each of the little cells in the uterine lining has a little TV antenna on top, and that's a receptor. That receptor is listening for the signal from the hormone. And the hormone is telling it to grow, it's telling it to slough off, it's telling it to get ready for implantation. Whatever the hormone is telling it to do, which in this case is to grow, it's hearing that. And so each little house has the same one TV antenna. It's hearing the same amount of hormone, and so it's growing nice and evenly. But one of those little houses has 40 TV antennas. One of those little areas inside the endometrium has 40 receptors. And so instead of hearing the signal that says grow and make it even like everything else, it's getting 40 times the signal. So you get that patch of weeds. It literally sticks up like a tree trunk or hangs down like an icicle. And that's what a polyp is. In some cases, those polyps can be precancerous. In most cases of people of reproductive age, they are benign growths, but they take up room that your embryo may want for transfer. So that's what an endometrial polyp is. Bryn Hojem says, Brandis just did my transfer on 9/6. How long does it take the HCG wash to usually leave the system? I got a very faint line today. Well, no, HCG wash is not absorbed into your system, Bryn. So it's really just a topical treatment for the endometrium. So it would not make your pregnancy test positive. Now, if you are on HCG boosters, that's something that can make your pregnancy test positive. But without the HCG boosters, that faint line is a real line. So congratulations and fingers crossed. Hey to Mariella. Maria King says, I'm seeing you for a transfer on Monday. Outstanding. My lining today was 9 millimeters and homogeneous. Should I be concerned about that? So the 9 millimeter number is great. That is a nice thickness to have of the uterine lining. So oftentimes what we are looking for is what's called a trilaminar lining, trilaminar, 3 layers. And when we look at the endometrium and we see 3 layers, really what we're seeing is 2 layers and that line that's between them. So that makes it 3. So 1, 2, 3 there on the bottom. That means it's appropriately and ideally estrogenized, but the homogeneous means that it's kind of, it all looks like sort of one layer. That is not a criteria that would make me say, oh, you shouldn't do a transfer, because oftentimes what it looks like beforehand when we go to do the transfer looks like it's trilaminar or having 3 layers. So I feel okay about that, Maria. I'm looking forward to seeing you on Monday. Macro Mama says, currently pregnant 8 weeks with your CNY miracle. Thanks to all those in Colorado. Gosh, you don't have any idea how much we love to hear those stories. Thank you so much. Let's see. Does Orilissa suppress endometriosis just in the ovaries, or can it take care of scar tissue outside the ovaries too? Can progestin do suppression for endometriosis? So the answer is Orilissa treats endometriosis no matter where it is. It turns down the signal for endometriosis. So endometriosis can be in the ovaries. It can be on any of the pelvic structures. It can be on the bowel, and it can be in the lining of the pelvis, which is known as the peritoneum. Can progesterone suppress endometriosis? Not commonly thought to be a suppressive agent. Now, you also asked there, Rosa, about scar tissue. Endometriosis can cause scar tissue, and the scar tissue is a separate issue because we can turn off the hormonally sensitive endometriosis, but the scar tissue, once it's there, is there. So just like this nice scar I have right here, which happened, well, I get my brother's not watching this, so I can say this. My brother threw me through a glass door when I was about 2 years old, and my parents are going, Randy! No. Okay, he didn't really, but it's a good story, and I'm sticking with it. I went through a glass door when I was 2 years old, but my brother obviously had something to do with it. There's no question in my mind, even though I don't even know that he was home. But in any event, the scar stays. There's nothing hormonally sensitive in that scar, but with endometriosis, it causes scarring, and the scarring will stay, but the endometriosis itself can be suppressed. Terrence Pope says, hi from Detroit. Hello, Terrence and wife. Can't wait to join the CNY team, and we are looking forward to that as well. Stephen Reno, thank you. I remember. Thank you for a wonderful retrieval yesterday. I'm glad that you are feeling well. Let's see who we've got over here on the Facebook, Instagram side. Good afternoon to all. Glad you guys are here at 20 minutes after the hour, and we are here until the top of the hour with Fertility with Fink and Friends. And as you know, I am Fink. You are friends. You got that right. Okay, Tracy says, hey, from Wisconsin. Part of my prescription order included letrozole. I did take that in the past for some timed intercourse and had no response. My dose started at 2.5, at 5, and then at 7.5. There were no responses. When I took Clomid, I did ovulate. So the reason letrozole is preferred, I'm nervous because it didn't work from before. So to answer that question, letrozole is sometimes used as an adjunct to the injectable medication for stimulation for IVF. It is not always used. There are some of our providers who love letrozole. So Dr. Kiltz loves letrozole and believes it should be used in everyone. Some of the rest of us prefer not to use it in everyone and to use it only in selected circumstances. However, letrozole is very inexpensive as a medication, and it is included as part of the bundle packages. So as I say, it's an adjunct. It is not in and of itself being used for ovulation induction, even though it helps. It's another pathway to help recruit follicles or try to help recruit eggs. But really what it's doing is that it lowers your estradiol levels. So if your estrogen level is a little lower, it may result in a little bit more of a hospitable environment for you to be able to have a fresh transfer. So why don't we use Clomid? Clomid has an effect also of lowering estrogen, but it has a direct effect on the uterine lining, and it can thin out the uterine lining. So if we're going to use Clomid in a cycle, then we don't want to be planning to do a fresh transfer because it will thin out the endometrium. And that's the reason why most of us tend to go with letrozole over Clomid if we're just doing ovulation induction for things like IUIs. Marcia says, if your beta was 4650 and the next 2 days later is 6940, if it's not doubling like it should, what can that indicate? So the first thing I would want to know there, Marcia, is have you had an ultrasound? So when your beta HCG level is above a 1500, then we know that we should be able to look by transvaginal ultrasound and see a pregnancy that is inside your uterus. So the most important thing to know is that it's an intrauterine pregnancy, that it is not an ectopic pregnancy. And so the first number that we use is 1500. We expect that as the number grows, it will double, but 2/3 of the pregnancies double, which means that 1/3 of them do not. Really more likely, we're looking for that doubling in the early part of pregnancy, ideally before we've even looked with the ultrasound to see where the pregnancy is. So, I would always want to know, do we see a heartbeat? So, Marcia, once we look and we see a heartbeat with that early ultrasound, then we know that 95% of those pregnancies are going to continue to grow. And that's the best odds we can hope for. So, which raises another question. People sometimes ask, when do you think it's okay to tell my family that I'm pregnant? So that used to be, we would say to people, well, maybe you want to wait until you're 12 weeks. Why 12 weeks? Well, that's the end of the first trimester. And the risk of a miscarriage dramatically goes down after 12 weeks. But nowadays, by ultrasound, if we look and we see that heartbeat, 95% chance that pregnancy is going to continue. So some people now opt to say, I will tell my family when I see the heartbeat. Food for thought once again. Dr. Andrea says, good evening, and good evening to you. Can you please explain the benefits of a fresh transfer after 4 unsuccessful frozen transfers? History of PCOS. I wouldn't necessarily say, Dr. Andrea, I said Andrea, and I think that is Anidra. So Anidra Marie Johnson. So please forgive me for mispronouncing. First of all, I'd say, well, you had unsuccessful frozen transfers, so maybe it makes sense to try something a little different. And so in that case, perhaps a fresh transfer. The data shows us that fresh transfers in general will have a lower success rate than frozen transfers. That will especially be true in someone with a history of PCOS. And why is that? Because when we're using the medications to rev up your ovaries for a retrieval, your body way gets into egg making mode. And once it's in egg making mode, that sometimes may not be consistent with getting pregnant mode. And that is especially true in folks with polycystic ovarian syndrome because you tend to be good responders to the medications, but your progesterone levels run high, your estradiol levels run high, and that creates a very inhospitable environment for an embryo. So, I would say I'd have to really kind of look at your history personally to see what the thoughts are about that. But my first thought is, well, it's something a little different than what you had done before. And so, maybe it's worth kind of trying to change things up. If all had been frozen transfers, maybe now considering trying a fresh transfer. Jamie Lynn says hi, and so does Marcia there. Michelle says, 2 more weeks till my consultation with one of the nurse practitioners, and I wanted to ask, I'm 28. I have PCOS and plan on doing a mini, I guess you mean mini stim with frozen embryo transfer, no testing. What are the steps after the egg retrieval to prepare for a transfer? Well, so first thing is you do your transfer, and about 10 days later, you will get your period. And when that period comes, we can start the process of either doing a medicated cycle or some form of a natural or a modified natural cycle. Steps before doing that, we certainly want to know that the uterine cavity is normal, that you've either had a saline sonogram or a hysteroscopy to make sure that there are no polyps or growths on the inside, something to stand in the way of that embryo implanting. And there is a list of supplements I recommend that is the evidence-based protocol for embryo transfer. That list of supplements is prenatal vitamin C, vitamin D. I'm sorry, I scratched that. Prenatal vitamin D, vitamin E, CoQ10, and L-arginine. The vitamin C is only important if you have a history of endometriosis. If you've had endometriosis, 600 milligrams of vitamin C should be part of both your retrieval and transfer protocol. That list, by the way, is available through my Linktree, linktr.ee/Randy Fink MD. I wrote a little book on that called The Vitamin Victory that is only $7 and will also get you a discount on those supplements if you'd like to buy them from a particular vendor. But it's got the whole list on there, and feel free to take a look at that. Randy Fink MD is also my Instagram. If you can't remember the word Linktree, it is the link that's in my bio. So there is an evidence-based protocol for egg retrieval, for embryo, for egg quality, for general fertility. There's that for diminished ovarian reserve. There is that for embryo transfer, and there's a specific list for egg quality, sperm quality. So take a look, won't you? Deanna Guzzo says, I had my IVF baby in June. Quick vaginal birth. Outstanding. When can I do another transfer? And or an egg retrieval? Well, so usually if you're thinking about doing another retrieval, I'd say about 3 months postpartum. We generally don't want you to be breastfeeding if you are, because the medications will affect both the breast milk and your supply. And and that's in order to be able to get eggs and make embryos. As for doing embryo transfers, the best evidence that says that the interval of time to have a baby after the first baby or after a baby is 1 to 5 years. That when you get pregnant too quickly after having had a baby, that is considered to be one of the only preventable risk factors for severe preterm birth. Well, that's very interesting, you say. So I'd say 6 to 9 months is a good time. 9 months feels like a good number to me to think about doing an embryo transfer. Hey to Michelle Marks, nice to see you as well. And Melissa Maloney says my successful transfer was from Brandis too. Oh, Brandis likes to hear that. She says congratulations. McRae Hind, I did my retrieval yesterday, got 21 eggs and only 9 fertilized. Why such a drop? Well, the first thing that I think of in that scenario is that when you make quantity, you may not be making quality. So the evidence shows us that really anything above 15 eggs retrieved does not improve the outcomes. So if we were going to look at your cycle for next time and say, well, what am I going to do here that's different? I might think about saying, well, I would drop your dose. I'd see about trying to get you fewer eggs, because I think if we got you fewer eggs, we'd probably get you better eggs. My thought. Progesterone suppositories, what are your thoughts on those for day 3 transfers, once or twice a day? Well, it kind of depends on whether you are doing a natural cycle or a medicated cycle. If you are doing I'm sorry, you said a fresh transfer. So you're doing a fresh transfer, that's a medicated cycle. Honestly, once a day is probably fine. The progesterone in oil is honestly really the only thing truly that you need, because the amount of progesterone that we measure in your body comes entirely from the injection. So if you're doing a medicated cycle and you say, I don't want to use that injection because I don't like it, it hurts, I don't want to do that, odds are your transfer will not be successful. Because in a medicated cycle, you need that progesterone injection, that the local effect of progesterone in the vagina is usually not enough to maintain a pregnancy. Now, we give you a little extra because it just makes sense. Again, it's a local effect. It's like putting hand cream on your hands. It just, helps a little bit. But I would say, once a day is really probably fine. The problem is that it doesn't stay there the whole time. So if you do it twice a day, then you're getting morning and you're getting night and you're having kind of full-time coverage. But really the most important thing is the progesterone in oil. Nakiba says, if your partner sperm morphology of 1% or less, what are your thoughts with IUI or IVF for myself at the age of 45? Well, it's a tough situation, Nakiba, and I will tell you what I think here. So first of all, sperm morphology is not considered to be a cause of infertility. Rather, it is an association with couples who have a hard time getting pregnant. So it's not thought to be something that prevents you from getting pregnant. It's just kind of associated with people who are having a hard time. At 45, the odds of getting pregnant through assisted reproduction are unfortunately very low. And that's the same as it is that the odds of getting pregnant, even spontaneously, it gets much harder for us to be able to get pregnant the more mature we are. When we are above about 40 years old, the odds of an IUI being successful are not significantly greater than the odds of home intercourse. So really the odds start to improve for IVF in women in their 40s, but particularly if you get a euploid embryo, which means that you produce a normal egg, you grow that out to the blastocyst stage, you biopsy that, do PGT testing, and you get a normal, chromosomally normal embryo. That embryo gives you a 65% chance of pregnancy. If you don't test that embryo, then your odds of success are not significantly greater than they would be with home intercourse alone, which is going to be less than 1%. So it's a challenging scenario at 45. And it's not to say that you can't get pregnant. You know how many times I've heard people, I've seen people come in pregnant and say, they told me I would never be able to get pregnant. And so I never say that to anyone unless you don't have a uterus. And that makes it a lot harder. There are always possibilities, but these are the kinds of things that we want to look at the numbers very carefully so that you don't embark down a path that's going to result in disappointment. So let us help. Glad you're here. Um, what AMH level is indicative of possible polycystic ovarian syndrome? There are different answers to that question. Certainly, if the number is greater than 5, then I start thinking that your ovaries will behave like polycystic ovaries. There are some studies that show us that if the number is greater than 3.5, you are at risk for hyperstimulation, the way you might be if you had polycystic ovaries. But so I generally think of it, Mary Ellie, as about 5. Journey to Baby W. What is the minimum you suggest being on Lupron depot? Well, if you're talking about for endometriosis, that's the most common reason that we use Lupron. If we're talking about being on Lupron to suppress endometriosis before transfer, it's 60 days. 60 days is all you need. Some people say, well, I would rather do 90 days, or I want to do 120 days, because if 60 days is good, then twice that much must be better. And the answer is for pregnancy, for embryo transfer, that's not true. The data shows us 60 days is really all you need to suppress endometriosis. Oh, let's see. How long does an HCG wash stay in the system? And again, it doesn't really stay. Oh, we talked about that, Bryn, just a minute ago. It doesn't really go in the system. It really just treats the lining. Okay. Lovely Onyx, I'm in my 5th month. What can I do to get my potassium level up? And should I be worried as I have no baby bump at this time? Well, so you are pregnant, and congratulations. That is fantastic. The baby bump it varies by person. There are some people, at 12 weeks of pregnancy who are already showing signs of pregnancy, and there's other people that by 24 or 30 weeks of pregnancy are first beginning to see the signs. It's usually around 20 weeks that you start to feel fetal movement. Potassium levels typically drop a little bit in pregnancy, especially if you have been vomiting, they will go down. But if there's concerns about potassium, one of the easiest and highest potassium foods you can eat is a banana. So eat a banana a day. It certainly, there's people talk about the sugar in that fruit, but banana a day will help to bring your potassium up there as well. Heavenly Joy, what supplements do I need to support the upcoming transfer this week? And do I necessarily need the wash, the lipids, and the acupuncture? Well, so we do think that, there is some data that says that acupuncture is helpful for pregnancy outcomes. So certainly I think it's pretty easy to do a pre and post transfer acupuncture treatment. It's not expensive. We have acupuncture on site, so it makes it pretty straightforward to do. I think that's easy. I think an intralipid infusion makes sense, at least one. What is it? It's like an IV version of the keto diet. It's a natural, it's a fat infusion. It's very strongly anti-inflammatory. Specifically, it is a treatment for natural killer cells. So, I kind of feel pretty good about intralipids, but it's not a deal breaker for sure. The HCG wash has controversial data. There's some studies that show us it helps people to get pregnant. What it's doing is putting that pregnancy hormone just inside the uterine lining. So it revs up some of those pregnancy implantation proteins. That sounds like a good idea, and the data supports it. Is it critical to do in everyone? And the answer there is no, but there are some people that it will help. So as far as supplements go, again, it's a prenatal vitamin E, vitamin D, CoQ10, and L-arginine. Do not take L-arginine for an egg retrieval, for egg quality cycle. Really, it's only for embryo transfer. All the other ones there are on the part of the list for egg quality, so everything but that L-arginine. How many hours of progesterone do you prefer for a 5-day frozen embryo transfer? It's 120 hours. So now it's 120 hours plus or minus 3. That's how much progesterone you get. And so that's how we decide kind of what time your transfer is going to be. Now, there is some data that says that our bodies probably have a little bit more leeway than that, but that's the classic wisdom, Nikki. 120 hours plus or minus 3. Let's see. Ryan says, thanks for all you do. My pleasure. I want to know what action plan you have for someone with stage 3 endometriosis for a higher chance of successful PGA tested embryo transfer. Okay, so you're talking about specifically for embryo transfer. You already have your tested normal embryos. Number 1, the supplement list. Prenatal, vitamin D, vitamin E, CoQ10, L-arginine. With endometriosis, you add vitamin C, 600 milligrams. Okay. Number 2, endometriosis. I want you to suppress that endometriosis for 60 days using either Lupron, or Alyssa, or Myfembree, and then go directly from your suppression into your transfer cycle. Don't take time off. Go directly into it. Those are the evidence-based solutions. And so fingers crossed there, Ryan. Let's see. Got that one already. I had a transfer on 8/26 and go this Friday for the first ultrasound. Awesome. That comes from Kaylan. Fabulous. Nicole asks, where can we get the onesies? And you know what? I got your message a little earlier. So first of all, I was gonna answer back. So if you saw on my Instagram, someone had a beautiful little onesie that was not going to fit me, unfortunately. And I don't think you want to see me try it on, but it said made by Fink in Colorado, which I loved, is fantastic. They made it themselves, and so I was actually going to text them if I could get you their number. But I do know that people on Etsy make those, and somebody told me today the name of the device, the name of the thing that lets you print on shirts, and I can't think of what she told me that thing was called. But that's what these folks did. They just made that themselves. But I will follow up with you on that, Nicole. Thank you for asking. What are the reasons for increasing success rate on consecutive transfers? Is it due to the physiologic changes on each transfer, or is it adjustments prior to next transfer? Well, so what you're talking about there is that when we do your first euploid embryo transfer, there is a 65% probability of pregnancy. Okay. By embryo number 2, that chance of pregnancy is 88%. By embryo number 3, that chance of pregnancy is 95%. All right. So when you say increasing success rates, that I think is what Ryan is talking about. Why do those numbers go up? Well, when we have a euploid or chromosomally normal embryo, that is our highest chance of success with IVF. But because of the way statistics work, it's not an additive process, that each individual transfer is its own separate mathematical equation. But if there were 65% each, then by the time you're at embryo transfer number 2, you would be at 130% probability of pregnancy. And you say, well, that doesn't make any sense. And you're right, it doesn't. And so that's why you see the numbers start to drop off, because you're never going to be at any point where transferring is going to be a 100% probability. So it's because you have excellent embryos, euploid embryos, and as you keep placing them, there's just a greater probability that one of them is going to stick, even if it's not the first one. Now, there are often not adjustments that we make to the cycle before you go into the second transfer. Why is that? Because medicated cycle, if everything works the way it's supposed to be, it is what it is. In a natural cycle, if the numbers all look good and everything works the way it's supposed to, the cycle, kind of is the cycle. The real question about those medicated versus ovulatory cycles are, where are you getting your estrogen and your progesterone. Either we're giving it to you in the form of a medicated cycle, or your body's making it itself. I happen to think that the natural cycles are a little easier on your body. You don't have to do the progesterone and oil shot, but sometimes it can be challenging, and sometimes it's better for us for different reasons to use the medicated cycles. So, but that is the reason, Ryan. Hopefully that makes sense for you. Paige says, hello, I am 53 and my husband is 28. My uterus is in great shape. The sperm also. I have been through menopause. What are my chances with a donor egg? I had one child at 38 years old. So your odds of pregnancy with a donor egg are extremely good. So usually in that scenario, what we would do there, Paige, is that we would give you some extra estrogen to kind of help you build a lining back to your uterus that has been gone since you've been in menopause and not making your own estrogen. So we'd like you to build some estrogen back, but using a donor egg, your odds of pregnancy are very, very high. And I wouldn't say that, it's an easy process, but it's a relatively straightforward process. The rate limiting step is kind of, we need you to evaluate the uterine cavity. I would recommend that you want to get a medical clearance or talk to your OB. Something just happened here. Looks like we lost camera. Oh, there we go. Now we're back again. I would want your OB to be comfortable taking care of you. And then it's kind of just about picking the egg donor that you want. And the rest of it's kind of done as part of a laboratory transaction. So pretty straightforward. Your odds are very, very good. We'll keep our fingers crossed for you. Darmelia says, how does ovarian rejuvenation work? And does it work as a treatment for premature ovarian insufficiency? Well, so when you say premature ovarian insufficiency, that can mean some different things. Some people use that terminology to mean a diminished ovarian reserve, that your AMH level is low, but it is existent. There is also a condition which we'll call premature ovarian failure. Some people use the term premature ovarian insufficiency as premature ovarian failure. And in premature ovarian failure, that is when basically your ovaries essentially stop working before you are 35 years old. So in that situation, I would not expect intra-ovarian PRP to make a difference. I have treated 100 or so women with premature ovarian failure in the hopes that doing something like intra-ovarian PRP would help to find an egg or make an egg, and I have not seen it successful. So I would not consider that to be a very worthwhile expenditure, in my opinion. Until we get some more data, something to guide us on that, I think that donor egg is still going to be your best choice. In the same scenario there, we get you pregnant with a donor egg next month. It really wouldn't require much because your uterus is not the problem. The problem is the hormones that the ovaries are making. So ovarian rejuvenation is not really a medical term, but it's what I call intra-ovarian PRP. PRP is platelet-rich plasma. And what that is where we take a tube of your blood and we separate out your body's what we call tissue components, your healing components, your growth factors, and we do something with it. So they inject it into the scalp to help regrow hair. You can use it. There's something called a vampire facial where it can be injected into some of these wrinkles that I have here, and use it to lift skin and to help falling collagen. It's used in joints, in damaged joints. In orthopedics. In fertility terms, what we're doing here is we're placing that directly into the ovaries with the hope that it may help to build up egg quality And that's really kind of the thing. There's nothing that we can do to put eggs back in the ovaries. You're born with all the eggs that you'll ever have, right? And again, you've probably heard me say this before. It's a little unfair, but the sperm that comes out today was manufactured in his body 3 months ago. Whereas the eggs in the ovary you were born with, they've been there since you were in utero. So, given that, over time, as we mature, the DNA in those eggs has a chance to become less stable, and so that's what we mean by egg quality. That the eggs may not be as strong, and the DNA, the genetic material in those eggs, may be abnormal. And so the thinking is, does intraovarian PRP have something to do with, can it improve that egg quality? It appears to be that the answer is yes, but again, it's considered experimental. At this point, we don't know who are the ideal people to do intraovarian PRP, and under what circumstances, what's the timing of it, and how often should you do it, and then how long should you wait afterwards to do a treatment. These are things we're still kind of guessing at, but they are studying these things, and we will hopefully have answers as the future rolls around. Let's see what else we got over there on Facebook. Angie says, I was treated for endometriosis. When is the best day for endometritis? When is the best day for rebiopsy? Well, there is no current evidence that says that rebiopsy is necessary. So you had an endometrial biopsy, a little straw that went inside, sucked a piece of tissue out, and they looked at it under the microscope, and they saw a bunch of plasma cells. Plasma cells are the marker for chronic endometritis. The endometrium is the uterine lining. Endometritis is an inflammation in that lining. It's not an infection, it's an inflammation. So plasma cells are the marker. So we usually treat that with some antibiotics, typically for 14 days. That is considered effective treatment. And I personally don't recommend a rebiopsy, because there are some people who are just chronically inflamed, and despite all the antibiotics that we can come up with, it never goes away, and it may not in and of itself be a problem. So we just don't really know what to do in that circumstance. However, I would say, gosh, if you were going to do it again, I'd recommend about 4 weeks after you completed your antibiotic treatment. All right, Angie, best of luck there. Kelsha says, if I transfer my embryos from Syracuse to Colorado, do you have a long wait for transfer appointments? No, transfer cycles begin pretty quickly. All of our locations tend to be limited on stem starts for IVF, because we are all limited in the number of embryologists we have. There is a shortage of embryologists in the United States. And so, if your period date, if today is cycle day 1, it may be a few days or even a week before we can start the IVF. So sometimes we'll do a little, give you some estrogen and progesterone, or even some birth control. People worry about that and think that that's a bad thing, and it's not actually. It juices up the ovaries. It talks to the pituitary gland in the brain, and gets it more ready to kind of start working. So there's no harm to doing that. And in fact, most IVF centers in the United States batch their cycles, which means that they only do them, let's say 2 weeks out of the month, or maybe 1 week every 2 months, or it just depends on what their volume is. Most centers batch, and so they will put people on birth control to get them into the right timing in order to be able to do IVF. Why do they batch? Well, they batch because availability of embryologists and availability of anesthesia. And otherwise, they spend their time doing monitoring visits and consultations, and focusing on other things like IUIs and so forth. In our situation, we don't batch because we're doing IVF retrievals and transfers really every day. But sometimes there may be a few days delay to start a stimulation. However, as far as embryo transfer goes, rarely, I have never seen a time where there's a delay there. Let's see here. Wanda, which is, I think that says, I'm excited that I'll be transferring in Colorado Springs on Friday. Excellent. Let's see. Liliana Gomez says, thank you for all your info. My pleasure. What do you think about the supplement PQQ and its combination with CoQ10 in fertility? That one, I have to say, I am PQQ. I am not so sure about. So I'm going to have to leave that one because I don't want to make up an answer. Ariel Eden says, hi from California. Let's see. Ashley says, can priming be done longer than 10 days? The week I think it will land on is not a good time for us to travel to Colorado. Just need to push it out a week. Yes, absolutely, you can. Some places will prime you for, for kind of a full month or sometimes even longer. So yes, Ashley, absolutely. Okay. P. Casas. Cassis, if I'm saying it wrong. Does BCL6 or endometriosis also cause second trimester losses? It is not known to. It is more associated with implantation failure. A second trimester loss is an extremely difficult thing for anyone to go through. And if you guys had to endure that, our hearts go out to you. For the strength that you have to do it again. So God bless. KG says, what does it mean when people say they are on an immune protocol and why would one be on one? So at CNY Fertility, we believe that the immune system has something to do with preventing people from getting pregnant. In most cases, there can be issues with the immune system. So we have 4 different levels of immune protocols, and these immune protocols have different medications, and different providers feel differently about which medications to use and under what circumstances and when to do level 2 versus level 3. Level 1 is very basic, so typically I think of level 1 immune protocol for folks who are doing IUIs. But once we start getting into more significant investments that people are making into IVF, then I feel like at least a level 2 and sometimes a level 3 is important. Now, everyone is not comfortable being on all the medications or the things that are associated with the immune protocol. So they are 100% voluntary. They are merely a recommendation. And so that's something that we can certainly talk about when we're looking at your protocol. Does an AMA with an AMH of 0.2, can I still do a modified natural FET after Orilissa for 2 months? Or do I need to do a medicated cycle? Well, a modified natural can work. Sometimes the only thing is that when you've been suppressed with Orilissa, you may find that your body is a little slower to respond. So modified natural can, is ovulation induction, and that may help to make it work. I would not recommend a natural cycle FET after suppression, or at least in that first month after suppression, because the body is going to be slow to respond. So if not a medicated, then at least a modified natural. If the modified natural isn't working, then you just change it over to a medicated cycle. And I think that works there, Rosa. Let's see here. What is the success rate for IVF for women at age 36? This comes from Terrence. Well, success rate really kind of depends on what you mean by that and on what you actually do. So it really depends on the type of embryo that you have. At age 36, if you go through IVF and you create blastocyst embryos, which is an embryo that's a day 5 embryo, and you don't test those embryos, then that embryo gives you about a 30 to 35% probability of pregnancy. If you test those embryos to see that they're chromosomally normal and you get one that's chromosomally normal, why then that's a 65% probability of pregnancy. So to come up with a success rate in an individual is really quite variable because it depends on a lot of other factors. Presence of fibroids, endometriosis, what is the ovarian reserve? Lots of variables go into that. Let's see if I can get one more question over here. I just had a medicated cycle FET, so I switched to a modified natural. I have day 3 embryos. I'd say if you did and that's Nate's wife, Kayla, if you did a medicated cycle, doesn't work, absolutely try a modified natural in the next one because, again, it's much easier on your body, in my opinion. Well, looks like, let's see. Let me see if I can get one more question here. What won't the saline sonogram show you that information? Not sure which information there, Janie Lynn, but it will show you what the saline sonogram shows what the uterine cavity looks like on the inside. It is top of the hour, and it is time for us to go. Boy, this hour slips by so fast every single week, but I am so happy you were able to join me here today, and I hope you'll do it again next week. If there's something you'd like to talk about, message me here, Randy Fink MD. Take a look at my link tree for the book, The Vitamin Victory. And, most importantly, the world is not a kind enough place. Every step forward with kindness. Watch the political debates tonight and see if you can glean any kindness from our political candidates, because, boy, the world needs more kindness, and I feel like each one of us can do something to change that and to make it a happier place. Every step forward with love and hope, knowing that yesterday is a memory and that the sun rises tomorrow and it is a new day with new hope for all the things that our future can bring. This whole fertility business is not the book of your life. It is only a chapter. And what are we doing? We are here to rewrite that chapter together. So until next week, I'm Dr. Randy Fink from Colorado Springs. I am Fink, you are friends, and I'll see you next week. Good night.